provider located here in sunny Southwest Florida. Today we're going to go over something that is very important to me, should be important to all men and women, and that is going to be female sexual health. I have a patient here today, Christina, who also works with us, and she has never been on hormone replacement therapy. We are just starting to do her evaluation. Typically, I try to have women do their blood work before they come in. I don't have that, but we're going to go over symptoms, the exam that we did do on her, because we can actually tell in women hormones that they're deficient in without even looking at blood work. Just based on exam, we can do that. And we start to pull all that information together by going over your exam, pelvic exam done here in the office, your blood work, and your symptoms. So what we're going to talk about today, I know a lot of you women know and understand, because this is something all women will go through. We have different stages in life where we are premenopausal and we're menstruating, we're having children, our hormones are fluctuating. Then we become perimenopausal, which is like an 8 to 10 year transition into menopause. Our hormones really significantly begin to fluctuate and we start to have changes in the body. Menstrual cycles become heavier, closer together. We begin to have symptoms that go along with it: pain, nausea, longer lasting periods, anxiety. There are a number of symptoms that come along with these changes. And then we transition into menopause. Average age of menopause, depending on the study you look at, is about 52. We are all heading in that direction. All women will be in menopause at some point in their life. The important thing to understand about that is once you are in menopause, it's a chronic state. You will live in menopause for the rest of your lifespan, and women will live 30 to 50% of their life in menopause. So yesterday I was 20 and then I blinked and I'm not, okay? We're all heading there. Now, for these stages in life, what we want to be able to identify in women is what symptoms you're having, the physiological changes in your body. You are no longer going to be making hormone once you are in menopause. You have secondary mechanisms, they all begin to fail. And then you begin to become symptomatic. There are changes in the body, especially the vulvovaginal tissue. We're talking about the vagina, okay? But that's not just the vagina. The vulva is actually that exterior anatomy. The vagina is the internal anatomy. Women will begin to have changes, and this is all women. Okay, so it's not unique. We need to understand that we have to be open about this and talk to our providers, because this is something that all women are going to have to deal with at some point. So as women in medicine, we have done an amazing job of taking care of women when it comes to pregnancy, STDs, and cancer outcomes. We've done a great job. The problem with that is that not all women will get an STD, not all women will have cancer, and not all women will have children, okay? So we can't just define women in those three areas of medicine, and that's kind of what we've done. We've left quality of life issues out for women. You know, when we're talking about things like hormone replacement therapy, which is essential for all men and women, 3 hormones specifically we're going to be talking about are testosterone, estrogen, and progesterone, but there are many more hormones in the body that we still need to address. But these 3 essential hormones, oftentimes women are told you can't have hormone. It's bad for you. It's cancer. You're going to have blood clots. You're going to have, heart attack. You're going to have a stroke. However, the problem with that is these hormones are essential for our bodies because they affect everything: skin, hair, nails, bone, memory, mood, concentration, the way you feel. They affect our anxiety and depression levels. Hormones don't change your stress. They help you cope with stress. They affect our sleep patterns, they affect our brains, hearts, kidneys, our urinary tracts, our inundated hormone receptors, just about every system in the body. So as you're in menopause and you no longer make those hormones, you begin to have changes in the body, and hormone is considered a right for a lot of people, except for when it comes to women. If you're on birth control and you don't want to have babies, it's a right. If you're transgender and you're transitioning, it's a right. If you're a man, your quality of life is affected, it's a right. Well, as women, we also have a right to that same quality of life. When you're talking about the stages of life that we go through in menopause, it's important for women because we've been conditioned by society and medicine to think that this is natural and a normal part of aging, and we just have to buck up, grin and bear it, and be ready for the ride. That is not true. We don't have to do that. We have the ability in today's world to address these deficiencies and maintain the health of women for the rest of their lifespan, regardless of things like cancer. Because even women with cancer have options for hormone replacement therapy. We cannot save your life and then destroy your quality of life. So the conversation that needs to be had with women is, how can I maintain your health and your quality of life without putting you at unnecessary risk? And what is that risk? Well, the answer to that is to keep your levels at the lowest, safest levels, so that if a woman does come down with cancer, because we don't know who will and who won't, we can just simply stop the hormone. But at a minimum, all those women should still be on vulvovaginal hormone replacement therapy to keep the vulvar vaginal tissue healthy. And we're going to discuss why that is so important. And we're talking about health outcomes later in life that actually affect not just our quality of life, but we're talking about life and death issues, and we'll get to that. And the entire goal of hormone replacement therapy, it isn't, as much as I want to maintain quality of life, it goes beyond quality of life for women, okay? So women will come in with the same complaints men do. My libido is down. Guys will say, I can't put any muscle on at the gym. Well, that's the same as us gaining weight. Their erection changes are equivalent to our vulvovaginal tissue changes. They also begin to have issues sometimes with ejaculation and orgasm. They'll have sleep disturbances. Men tend to get night sweats, but women will also get hot flashes and night sweats. They'll come in and they're complaining about brain fog, concentration, memory. All of those same things we complain about to our providers, we are again told it's normal and it is the way that life is for women. But we don't say that to men, okay? Now, some of the things that we did your exam already, and we can begin to look at the symptoms that you're having with, dryness. Some women will also get itching. The itching is not a yeast infection. This drives me crazy. If you are a woman and you have significant atrophy, you have a dry vagina, your pH has changed, you do not have a yeast infection. The itching is caused from women. The tissue is starving for hormone because it's 100% hormone dependent, and it is saying, I need help. The itching is the tissue trying to heal itself. Like when you're younger, you injure yourself and it's starting to heal and it gets really itchy. So these women who come and they have significant atrophy, and what that means is the tissue is beginning to shrink. It is thinning. It tears easily. The body is actually reabsorbing that anatomy. So everything will disappear. The labia, the clitoris, all of that anatomy begins to disappear. The itching is caused because that tissue wants to be healthy. It's 100% dependent on hormone. If there was an alternative, I would already be using it. Laser therapies, PRP, radiofrequency, those are adjunct treatments. They're meant to be used in conjunction with hormone. You have to grow the anatomy back to get it healthy. I mean, we're doing boric acid treatments on women for yeast infections, things they don't even have. We're giving them medications for conditions they don't even have because we're conditioning them in medicine to believe the reason you have this frequency, urgency, pain, and burning is because you have a urinary tract infection. I didn't send it off for culture. I didn't verify that. I just did a urinalysis, dipstick in the office, or I didn't even do that. I'm just going based off the symptoms you're reporting to me. And what's actually happened in younger women who are closer to menopause, it really is an infection. I've even catheterized women in the office to get a sterile specimen, sent it off, comes back negative. Okay, a lot of cultures are contaminated. So you're treating these women for infections they don't even have because the symptoms are the same. The tissue has started to get reabsorbed by the body because of the lack of hormone, and it's become raw, and it's painful. The pH has changed, and now you're urinating on it. The symptoms are the same as an infection. So really, as providers, we need to be verifying that. I do cultures, and if I highly question it, I will actually catheterize women in the office to send off a specimen because I don't want women to think that the problem they are having is an infection when in fact it's the lack of hormone in the vulvovaginal tissue atrophy. So when you come into my office, I do a very specific exam. This is the first time you ever experienced something like this, right?
Yeah.
We do what's called a vulvoscopy. We actually will also take pictures of the anatomy because we're measuring the degree of atrophy. And it's very important to do that because if we're going to be treating a woman, we want her to understand that all of this has to do with not just you feeling better, but the underlying reason to do hormone replacement therapy in women is to keep the vulvovaginal tissue healthy and will improve health outcomes later in life. Because when the anatomy disappears, the older and advanced aged a woman gets, all of that anatomy will begin to disappear. She'll be left with a hole. That's it. Everything begins to disappear, and as women, we don't even know our own anatomy, so we don't even know and understand it's happening to us. That's part of the point for the vulvoscopy, because they can see the exam as well, and you were just kind of like, I don't want to see it at all.
I did one too at first, but it was, I didn't know your anatomy would even do that.
Yeah.
I didn't know it would disappear like that.
Yeah, I mean, if we don't understand what is normal, how are we
So
going to
actually
identify
watch it,
and
it's
understand
pretty
what
cool,
is
yeah.
abnormal? So we actually measure the clitoris, the labia. There are certain areas that we touch and that we're checking for the health of the tissue. They don't do this in a standard GYN exam, so I still always recommend my patients to see GYN, get their PAPs done. I do everything short of the PAP because I don't treat those conditions, and I want the GYNs to feel comfortable enough to refer to me because I'm not their competition. All right, so I let the experts do what the experts do, right? So in this exam, oftentimes we're able to identify just based on the exam what hormones women are deficient in. Now for you, we identified that you had some clitoral atrophy. That tells me there's a testosterone deficiency there because the clitoris is testosterone dependent. Everything from the clitoris to the vaginal opening is very testosterone dependent. There were some areas that I touched, some glands that you had a little discomfort in. Women shouldn't even feel me touching that tissue. The vagina is meant to be warm, wet. You're meant to have discharge, okay, and a certain pH balance. But when you look at the tissue and it has, some pallor in it, now it's pale and it's kind of white. I always tell women, I have two things in this office. It's very rare I have a normal vagina that walks through the door. So normally I get two things. I get what I call my sad vaginas and my angry vaginas. Either they're very pale and just kind of blah and the anatomy has begun to disappear, or it's like bright red, angry, and screaming at me because they're having a lot of pain, okay? And again, as women, it's bullshit. Like, we should not have to deal with that standard, buck up, you're a woman.
Yeah, pretty much.
You're like this because you have a career, you have kids, you're busy, you're in school, you have a husband, you have whatever the excuse is. It's something other than, hey, you may have a hormonal deficiency. And we treat a lot of women for conditions with Band-Aid approaches, and we're okay doing that in medicine. I'm going to give you this medication to fix the symptom that you are now having because of your lack of hormones. You fix the underlying problems. That's what we should be working on. Band-Aid treatments like antibiotics for infections people don't have, totally inappropriate. If a woman has an infection, absolutely, she should be treated with her antibiotics. But you can prevent the infections altogether just by restoring the health of the vulvovaginal tissue. And that is the entire point to hormone replacement therapy, not just to help women feel better. We live deficient in hormones for decades and don't even realize that this is happening to us because we are told by medicine, here's your birth control. Oral birth control, we are now understanding, forever alters hormonal pathways. Once we give you this birth control, it alters and changes the hormonal pathways. Doesn't matter how long you take it. It forever alters them, and they never go back to what they would have been had you not started it to begin with. And we're finding women deficient in testosterone and progesterone, okay? So if you think about that, even as medical providers, sometimes when medical providers hear this, they're freaking out because they're like, whoa, 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 birth control. Don't take away this access. I'm not trying to take away the access. I just think that women need to be informed. This is going to physiologically change their bodies because it will deprive them of the testosterone. I see 20-year-olds in here. When I do their exam, it's like I'm seeing a 70-year-old woman on my table. That is inappropriate. We're starting young girls on oral birth control at 9 to regulate menstrual cycles, acne, and conditions that we really should just let them work through naturally. Okay? A lot of that is happening because of what's in our food and the chemicals we're being exposed to. Everybody is okay with all of that stuff because it's got the government stamp of approval, but it's really not. Like, we're fortunate enough to have that access here, but it comes at a price, and we need to start understanding that these are the things that are happening to us. We're changing women's bodies through birth control. When birth control first came out, they took it to indigent areas, gave it to women, and it sterilized them. So then they were like, well, we got to change this. We can't be sterilizing women. The formula is still the formula. It's not severe enough to sterilize women when they're on it for a short period of time. But how many women every year undergo IVF that have been on birth control for decades? Then they come off, they try to get pregnant, and they can't because their hormones are all out of whack. Okay? And the treatment to get them to get pregnant and have a successful pregnancy oftentimes is high doses of hormone replacement therapy. Okay? So we were able to identify some of the atrophy. Some of the labia was beginning to disappear, the labia minora. And again, these are things that we don't really look at or think about. The clitoris is beginning to disappear. The clitoris, you only see that little button, but the clitoris is actually 2 to 4 inches long. Okay? Most of it is internal. It's an erectile organ. Our clitoris, the anatomy is the same as the male penile tissue. It's an erectile organ. The hood is the foreskin on a man, and we have the same 2 chambers, okay, that they do, the corpus cavernosum. So when you look at that, just like in men, hormones are very important for them to maintain their quality of life, very important for penile tissue health. They are for us as well, all right? And it's not just estrogen. We are not only made of estrogen. It's sad because when you look at women who go through certain procedures like hysterectomies or partial hysterectomies and the uterus is removed, now women are being told you don't need progesterone, but progesterone does so much more in the body, okay? Don't define women by their uterus or their ability to have children, or the cancer that they have. Okay, progesterone in the body protects the hair follicle. Our brains are progesterone dependent. It has a role on healing in the brain. If you sustain any type of traumatic brain injury, it has a role on the protective myelin sheath. Now they're doing studies on testosterone replacement therapy and multiple sclerosis, a neuromuscular disorder. Testosterone also has a role on the myelin. So we have to be looking at these things. Should we be looking more into hormone replacement therapy to start as a baseline to treat some of these other conditions that people are getting? But you have to address the underlying cause, otherwise you're just throwing Band-Aids at it, right?
Right.
Makes sense? So, again, you can start to see in your exam with some of the labia beginning to disappear, the clitoris beginning to atrophy, your pH was normal. The tissue was very pale, flat. What does that mean? When I'm doing the internal exam and I'm opening my speculum, that tissue should fill the space because I turn it sideways and I'm opening up that speculum. That tissue should be healthy and it should fill that space, but it just kind of lingers there. It doesn't really do much. The color doesn't really return to it. That's not what the vagina is meant to look like. The longer a woman goes, the more that anatomy disappears, the longer it will take for me to grow it back. When a woman comes in and I'm just left with no anatomy, it can take me like 2 years to grow that anatomy back. We shouldn't be letting women get to that point. Because the older advanced age a woman gets, and now she's 70, 80, or 90, and her immune system has changed, she's going to be susceptible to infections. You've created an environment where bacteria can thrive. And now she's going to have bladder infections that turn into kidney infections that turn into what we call sepsis or urosepsis. Most people know it as like a blood infection. And there was a study in 2019, it was a worldwide study that showed 1 in 5 people die from sepsis. That was just general sepsis. Our health outcomes are much better in the United States, and this is where you have to be careful with studies. They're much better in the United States than they are in a lot of other countries, but sepsis and urosepsis, it's still on that list of top 10 reasons why, that lead to death. So we could be preventing so many hospitalizations and death in women just by explaining to them they have got to keep their vaginas healthy. It is not just a sexual tool. It's great for sex. If you're using it for that, we need to protect that mechanism in women, especially the orgasm, okay? Because women will, when the clitoris begins to atrophy and it atrophies enough, women will lose the ability to orgasm. And that's just a travesty. Like if you're sexually active, we should be protecting that mechanism for women just like we do for men, okay? Because orgasms are amazing for women. You sleep better, you burn calories, it clears your mind. There are a million reasons why women should be having orgasms. Now, when we talk about orgasms in women, they'll notice changes at first. They'll become kind of diminished, not as strong as they used to be. They'll get harder to achieve. Orgasm is one of those things where when you're talking to women, it's a very difficult conversation to have. Because again, we've been conditioned by society as it is to understand that our vaginas are taboo. We don't want to talk about it, right? And when I say it that way, it's not because I don't know the anatomy. I'm just trying to, most people in the general population, they just talk about vaginas. They don't talk about anything else. So saying vulvo-vaginal all the time gets kind of exhausting. So our vaginas, they're not taboo. They affect our overall health. The orgasms for a sexually active woman are important. When that clitoris begins to atrophy, women will have changes in that orgasm, but sometimes women don't even know, okay? Because only 25% of women can actually orgasm with intercourse. Studies show 80% of women will fake it, having an orgasm. They don't understand what drives that. They've even measured orgasm in women, because you can measure it. Orgasm is defined as the involuntary contractions of the muscles down there, but you know when you have it. It's all over. You feel it from head to toe. You contract in the pelvic floor muscles, but you'll also be contracting in other areas, and you know it. Now, that being said, you have a lot of women who they're not sure if they orgasmed, because we're not taught this. We're taught to be out of touch with ourselves and our anatomy and our sexuality. So when they measure orgasm, they can actually measure it on ultrasound. And what they found was the majority of women who were reporting having an orgasm didn't actually have an orgasm based on this imaging. They didn't have the contracting and the involuntary contractions. What drives that in women? Who knows? Who gives a shit? But my take on that, don't fake it. Like, be true to it. Guide your partners. You have to learn to work together in the intimacy and learn how to please each other sexually. Most guys are going to be open to that. They're going to be like, hell yeah, let's do it. And they're going to want to figure it out, okay? And toys. Toys can sometimes be essential. It's actually prescriptive therapy sometimes in my practice. If I have a woman who has really lost the ability to orgasm, and if she's never used a vibrator, I will show her how to use a clitoral stimulator, and she will use it as that tissue gets healthier and healthier, and when she's finally able to orgasm, she'll report that back to me. And a lot of those women are like, the hell have I been missing? I've never had anything like that before. So we need to understand our bodies, okay? You've noticed, have you noticed some changes in your ability to achieve an orgasm?
Before the procedure or after? Yeah.
Okay. We did an O shot on her.
Yeah.
So most of the times when I do O shots in the office, I won't do them until I have a woman on hormone. I've seen women in here with such severe clitoral atrophy, there's no clitoris present, there's no way I can inject that. I have got to get that tissue to grow back first. And there is no alternative. Again, you have to use the hormone. The good thing is there's differences in hormone replacement therapy. If I use vulvovaginal hormone replacement therapy in a woman, this is creams and suppositories that she's applying directly to the tissue. It has very little to no systemic absorption. So if I draw her labs, it's not working in the rest of the body. The tissue is so greedy, it's only working on that when you apply it. Which is why even women with cancer should be, at a minimum, on vulvovaginal hormone replacement therapy for the rest of their lifespan. Once atrophy is identified, women need to be on some type of hormone. I usually do a combination of both because I want to grow the anatomy back as quickly as I can. Then women will cut back on those treatments and they'll just be left on their systemic hormone. And they feel better. The anatomy is better. If they are, I have a lot of women who aren't sexually active, that's okay. You don't have to be on hormone replacement therapy to be sexually active. Remember, we're talking about health outcomes. Don't wait to come to me at 80 when you're in distress. When you do that, it's going to take me much longer to grow that tissue back. And then do you know how hard it is to put an 80-year-old who is not sexually active on hormone replacement therapy and she comes to you with these frequent infections? It is very difficult. Because when I start telling her we're going to grow her vagina back, she's like, the hell you are. I haven't seen that in decades, and now you want me to touch it and apply this cream to it, and you want to grow it back? Like, I haven't even thought about that. But it is so important to their overall health. It's just really hard to get them on the hormone replacement therapy. And it's really hard to get women to stay on these therapies because they're waiting to see how they feel. They want to feel better. A lot of them could care less about the tissue. They want to feel better, but what they don't understand is you really live decades deficient in these hormones because of that birth control that most women have started at some point in their life. There's no way you're going to go to a medical provider and he's going to put you on hormone and he's going to fix your life in a couple weeks, a month, 2 months. It can take a year for some of my patients to physically feel the benefit of the hormone. It's very hard to get women to stay on it when it takes a year. But if they do it, they'll feel the difference and they'll understand that this is how they were always supposed to be and live, because it really does affect their quality of life. So, you know, with you, the biggest thing is we're going to get the blood work. If I have just the pelvic exam, you know, I can start a woman on vulvovaginal hormone replacement therapy, but I don't ever start her on systemic therapy until I have labs, meaning I'm going to give you hormone that's going to work everywhere in the body. Draw those labs, I'm going to have and see that reflected, and it will it will help you with some of these symptoms that you're having. So that does require blood work. Any questions on the background information with hormone replacement therapy in women in medicine and kind of where we've gone with that?
No, I think you pretty much just covered it.
Okay. So now, you know, we talk about options in women. There are, you know, vulvovaginal hormone replacement therapy is creams and suppositories you apply directly to the tissue. Again, very little to no systemic absorption. Every woman can be on that. Then there's systemic hormone replacement therapy, where we give you the hormone and we see those numbers reflected. There's a difference between bioidentical hormone replacement therapy and synthetic animal-based hormone therapy. They're specifically just talking about estrogen, commercial products. Most of them are animal-based. There's a new one that is plant-based. It's a new medication called Bijuva. The problem that I have with a lot of those medications is they're fixed, and you can't adjust and individually tailor those to your patients. But I don't have a problem putting women on commercial products, because if they need insurance coverage, I want them to have access to care, okay? It doesn't actually matter to me if they're on the commercial products versus the bioidentical. I would prefer the bioidentical because it is considered closer to our naturally occurring hormones. It's plant-based, but not all women can afford them. We're working more off of keeping you in those safe ranges, again, so that we're not putting you at unnecessary risk. Hormones do not cause cancer, period. They feed cancer. That's the difference. So our goal is not to overdose women and take them to excessive levels. When you talk about hormone and the little bit of hormone a woman needs, she should be more worried about the American diet, the sugar in that diet, and the chemicals that we are exposed to in the hormone disruptors over the little bit of hormone that she actually needs to maintain her quality of life and her sanity. You can maintain a woman's health. Estrogen is what they worry about the most when it comes to cancer, because there's a lot of female-driven cancers. You know, when you talk about estrogen replacement therapy, I'm trying to maintain my women at very low levels. 25 to 50 is all you need. Premenopausal women will run into the hundreds based on where they are in their menstrual cycle throughout the month, and they can run up to like 400, okay? Or typically run up to about 400. So 25 to 50 is very low, and that's all a woman needs to stay healthy. Even cancer patients, you can't take all the estrogen away from them. So there's a goal. I'm actually starting to get patients here where even their cancer doctors are trying to keep them in ranges of about 15 to 20. Okay? I'll take something over nothing. Okay. When you talk about the estradiol, they're really worried about cancer when it comes to that. They're also worried, interestingly enough to me, about blood clotting. But yet we put transgenders transitioning. I don't have a problem with that. I have all the protocols for that. I don't have transgender patients in my practice. But it's a right for them, and we don't even question it. Okay. I've had patients come in who could never be on hormone because they had a blood clot. Okay, so they took them off all of their birth control, 20-something-year-old woman. She just had gastric bypass surgery, and she got a blood clot in the hospital. It was her hormone. It is the easiest thing to point the finger at. It couldn't possibly have been the fact that she was overweight, just had gastric bypass surgery, and was stationary and not really moving a whole lot. You know, it had everything to do with her hormone. So now you have a young 20-year-old woman that you were telling has to be hormone deprived for the rest of her life. She's not going to be able to. She's going to lose her marriage. You know, her quality of life is going to be poor. We can't do that to women. That's unacceptable. Okay, so it's really about balance in those hormones. systemic hormone-wise, I can anticipate what we're going to see when we do get your blood work back. There's no study to date when it comes to testosterone replacement therapy in women that shows cancer in women. A lot of providers are concerned because testosterone can convert into estrogen, but again, it's about that balance. I'm not trying to overdose anybody on these medications. If I'm giving you the testosterone that your body needs, you're going to effectively metabolize it and use it. I shouldn't have much of a problem with women over-converting that into estrogen. And I actually don't have a problem. I did during COVID, because you had women who were super active. All of a sudden they're not. They're not using their testosterone, and so it's over-converting to estrogen. They started gaining weight, so we just adjust the medications.
So does your body use it just from
activity.
Activity.
So I can give you, and your body uses it in different systems. So I can give anybody the testosterone, but I cannot help them to use it. All right, your body will take what it needs for all this other background stuff. But when it comes to like the building muscle and stuff, it's not like these guys at the gym that are like overdosing themselves on testosterone. This is just to make you feel your best and normal. Build up a little muscle mass, feel better. You build muscle, you lose a little bit of fat. It takes forever in women. Okay, we're more complicated than men. Men think about losing 5 pounds, they lose 10. Women think about losing 5, we gain 10. But you eventually get to where you are. And I always tell women, you may not actually lose weight, because we fixate on the weight. You may actually gain weight or stay where you are, so you have to really pay attention to your clothes, because once you start to build that muscle, you'll lose fat, and muscle weighs more than fat, so they will actually gain weight, and yet they go into their closet and they try on everything that they have, and they fit really well. So you may have to judge it based on that. So no study to date that shows a correlation between cancer and testosterone replacement therapy in women. Testosterone is considered off-label use. It is not FDA approved in women, but this is not a new therapy. We have been using testosterone in women since it rolled out in the 1930s. Okay, we've been using it in both men and women. Once, I think in the 40s or 50s, there was a drug company that tried to get testosterone FDA approved in women. However, they failed miserably. Okay, we don't need as much testosterone as men do. There is no drug company that is ever going to pick up and develop a product for women, because it takes a lot of women, it takes a lot of money, and many years to get medications approved. Drugs for women are much more scrutinized than they are for men. It's hard enough for them to get that approved for men. They'll never get it approved for women, okay? But it's not a new therapy. And, again, progesterone, oftentimes considered not as important a hormone. Women who've had hysterectomies, they'll take away they won't even give them progesterone, but it balances our estradiol levels. So you'll have women who are put on estrogen, but they feel like they're crawling out of their skin, and they don't understand why they're so emotional and why they're crying over everything. And it's because they have these great estrogen levels when they've had a partial hysterectomy. They're still making these hormones, but they have no progesterone. You give them the progesterone, and they feel better. It helps them with some of their anxiety, symptoms that they might get with it, because some women will still have nausea and headaches and everything that comes along with the menstrual cycle, even though they don't have the menstrual cycle if they've had a partial hysterectomy. It's just as important for them to have that progesterone in the body, with or without a uterus. So when it comes to prescriptive therapy, I try to give my patients options on what might best meet their needs, whether it's a commercial product versus a plant-based product. And the biggest key for me is just informing patients of what they need, okay? And then we'll go over, separately from this, we'll actually talk about each of the treatment options and what I would normally prescribe, and how to get you optimized on your hormones, so that you are living the life that you should always live. Okay. Any questions?
Now, like the vaginal therapy cream, is that like forever? Like
Forever. Okay. And again, we're not just treating how you're feeling now, we're ensuring better health outcomes later in life. Okay? And that's just one example of where we can be saving women from health outcomes that they don't even need to suffer through. I get a lot of women in here with anxiety and depression. They're being managed on their antidepressants. If you have a woman who has never had a history of anxiety and depression, all of a sudden out of nowhere, she can't control it. She doesn't know what's wrong with her. We're managing her on antidepressants. We're not getting anywhere. I mean, this will go on for years. We really need to be looking at hormone. Okay, I'm not saying antidepressants don't have a place in medicine, but should we be doing a more, again, multimodal approach to care? All of these things together help to make women feel their best. Okay. And remind me again, you're not on anything for your anxiety, right? So again, the hormones don't take the anxiety away.
And I've not always had anxiety. This has just been like a new thing within the last several years.
Yeah, the hormones will help you cope with that, whatever is setting that off, or whatever that trigger is. It will help you to cope with it. It doesn't take away the stress, but a lot of women will find that once they start hormone replacement therapy, they feel better. They're not as anxious. They're able to function. They can think straight again. Sometimes we don't even realize that we're walking around, like men know. When they're in a brain fog, they know it's happening. But as women, we live like this for so long because we're deficient at such early ages, we don't even realize it's happening to us. And once the hormones start to get back into the body, and the body gets back to a normal state, it's like women are waking up and they're just like, oh my God, like I should have always been like this. And I've had women say that. They can look back on their entire lifetime.
They always knew something was off, but trying to figure out who to go to. Who do you go to for that? You just never know.
That's right.
And then you go to like a doctor and they're like, oh, it's just this. It's just, here, just take this. It'll make you feel better. And
yeah, and these are the things, it happens to all of us women. And, as a woman, I got into this wanting to know, would this be me someday? Only to find out that, yes, it would be. It's all of us. Men have their own problems as well. We're all heading in the same direction, okay? How do you want to head in that direction? Again, we have the ability to address these deficiencies. Back in the day, if you think about it, a lot of women died around the time of menopause. They hemorrhaged. They understand now that the risks are the same if the hormones are too high or too low. Cardiac, heart attack, stroke, the risks are the same. They're too high or too low. So, we're actually getting a lot of patients returning because their medical providers are understanding those risks and sending them back for hormone replacement therapy. Okay. And you're right, it's hard to navigate the healthcare system. It's hard for providers to navigate the healthcare system. And finding the provider who is going to understand this and help you with this, those providers that do it, we fight every day against the system, okay? Because for so long, it's been telling everyone that this is bad for people. The study that really damaged hormone for women, the WHI study, came out in, I think, the early 2000s, and basically said that if you put a woman on hormone, she's going to get cancer, she'll have a heart attack, she'll have a stroke, and women were taken off hormone all over the world. And as a result of that, a lot of those women, they went crazy. They were like, I can't live like this. I thought I was done with menopause. No, you're still in menopause. So those providers that listened to those women put them back on hormone and said, we have to figure this out. What is that balance? Newer studies are showing better health outcomes the sooner a woman can get on hormone replacement therapy at the onset of menopause. Studies are showing with estrogen replacement therapy and a vitamin D, because there's a lot of vitamin D deficiencies out there, it's increasing bone density, decreasing risk of fracture later in life. And newer studies are actually showing that with estrogen and testosterone, it's increasing bone density with that vitamin D, decreasing risk of fracture later in life. So, there's a lot of health outcomes that you can actually tie to hormonal deficiencies. If the research isn't done specifically to look at hormone, but if you start looking at things, I had talked about frozen shoulder in women. If you look at that, or frozen shoulder in general, if you look at the demographic of people that are affected by that most, it's perimenopausal to menopausal women. It's a hormonal thing. Women will get pain in the shoulder, and either, some women will have bone spurs, things like that, and then they're unable to really move and function because of the pain that they're having. So the answer to that is surgery, or they go through injections for a period of time, find out the injections aren't really going to do much for them. Yeah, so then they end up getting surgery. And they go in and they clear out any arthritis and bone spurs and stuff that women may have in there. But we should be looking at, are a lot of these conditions, are women leading into them because of hormonal deficiencies that they've been dealing with, again, for decades. And we have caused those deficiencies.
This is as far back as my arm will go right now.
Yeah.
Because I can't.
Yeah, and you should have full range of motion.
Yeah.
How old are you?
48.
Yeah, you should have full range
I can't,
of motion.
I mean, I can't, it pops and cracks and.
Yeah. And I have had patients,
funky, like,
you put them on the testosterone and the other hormones, and all of a
I
sudden,
have to take a deep
joint
breath
pain starts to get better.
to undo my bra. It's like, okay, this
Yeah.
is gonna hurt, and it does. It just, and I don't know what I've done, or if anything, it hurts right through there.
And again, you think about it. So testosterone is what helps us to maintain that muscle mass. If we've been deficient for decades, no wonder we start to get weaker and weaker, and things start to hurt. And even if you go to the gym, for women, I have women who they're fit their entire life, and then all of a sudden they hit a stage where they're hitting a wall. They start gaining weight. They cannot put on any muscle, and then you start getting some of these other conditions, where they're having pain and joint pain and back pain and all this other stuff. Then you put them back on the hormone. Now they can rebuild that muscle back to a healthy state, and they're feeling physically better.
Let's see that shoulder. I got bursitis in my calf. So yeah, I'm just a mess.
Yeah. And you're too young for that. So let's get you fixed up.
I can't grab anything with my arm. I can't walk, so I don't know.
Yeah. We'll get you fixed up. All right. Any questions?
No.
So if you kind of like what you heard, or anything here resonated with you, just know that there is help for you out there. You have to find the right provider. You want to find a provider who is, going to specialize in the hormone replacement therapy, but also a provider that you can connect with, that is going to listen to you, that will understand you, and that you feel comfortable with. And they are out there, trust me. There's a good website that you can go to. It's Ishwish, ISSWSH. They have where you can put in information based on where you live, and you can find a provider in your area that specializes in sexual medicine. You can, if you like what I said here today, I'll have more videos. I'm going to break this content up into smaller topics so I can talk more in detail on that information. So you can visit our website at sexties.com, SEXTYS.com. You can email us if you want any more information at info at sexties, SEXTYS.com. Or shoot us a text or call us at 239-351-5663. You can subscribe to my YouTube channel, Dr.Mel Irvine, IRVINE, and we hope to hear from you.